Well, you've had a long day and lots of talks. I promise to be very brief, 5 minutes at most, no slides, and mainly anecdotes. I used to ask SPR trainees in tutorials, what are you doing today in pediatric practice that you will look at or laugh at or deride in 30 years' time? And I got little feedback. When I first started pediatrics, when I look back in 30, I think in 30 years' time, they will look back at today and say, immunization was terrible, all those needles, as they hand out DNA cocktails to the children. They will say that immunotherapies will have replaced chemotherapies. There will be a huge number of enzyme replacement treatments at great cost. And lots of biochemical medicines will be like sugar today, transcutaneous, and many more. But back to the past. When I started pediatric training in the early 70s, when we were stuck, we used to take blood from the anterior fontanelle for routine biochemistry, believe it or not. Ridiculous. We used to put rubber bands around the children's heads and scalps to prevent their hair falling out following IV 6-parapurine, which is also ridiculous. We used to replace a plaster of Paris over scalp vein infusions. The smallest butterfly then was 21 gauge, and there was no plastic cannula, so that you had to get it to stay. And believe me, they were very precious. I remember vividly doing my neonatal stint in Hollow Street in 1971. Hollow Street was then the centre for Reese disease. And we used to be up all night doing exchange transfusions, looking at the nurse, 20 in, 20 out, how are we doing? And the infants were tied to a crucifix, in my time anyway. In 1972, I was working in Bristol in the Children's Hospital there, and during my stay, a premature gorilla was admitted to the NICU for a week for management of RDS, and we were curious as to what the normal potassium was in a baby gorilla, but anyway. She got the Gregory Boss treatment, because one of the pediatricians in Bristol then was Dr. Zoo, where Caroline, the baby gorilla's mother, had been having difficulty conceiving. There was no fuss, no press, no nothing. Nothing happened afterwards. In some hospitals I worked in, we routinely LP'd all children following febrile convulsions. And we got good LPs. Fortunately, nothing serious happened to my memory. We occasionally admitted children for the management of enuresis to hospital. That stopped. So did the enuresis. When working in the Children's Hospital in Bristol in 1973, there was an outbreak of diphtheria, because there was a scare then about pertussis vaccine, which was part of the diphtheria, tetanus, pertussis 3-in-1, and so parents were refusing to have it. And there was one ward in the Children's Hospital in Brisbane where there was a diphtheria alarm. If you pressed that, an old geezer called Charlie Feiston would appear in the ward with a scalpel ready to do a tracheostomy. He was the director of the hospital. I also saw, working in Australia, dehydrated children referred from the bush to Brisbane, having received 200 or 300 mils of IV fluid, IM, in both thighs, to get them over the journey, because it took hours to get into the hospital. In the hospital, then we occasionally used intraperitoneal fluid for the primary treatment of dehydration. As I say, the smallest cannula was 21 gauges. They were hard to get. You remember, Frida? And then I was back to the gorillas in Children's Hospital Philadelphia in 1976, and on call one night when an infant gorilla was admitted by a resident at the behest of a member of the Kennedy family, who was the director of the zoo. The senior resident arrived in about 6 o'clock in the morning, as they did then and still do, and said very quickly, get that effing gorilla out of here pronto. Litigation was much of a lesser evil in the 70s than now, and investigations were more basic, scans few, no CTs, no MRIs, but I think ultrasound started in the early 70s. In the year I was born, sadly, in 1943, some 500 Irish children, I think it was a serious underestimate, were recorded as dying each year, every year, from tuberculosis, measles, pertussis, polio, and diphtheria. 500, I say it was much, twice as many as that. That's all that were recorded. It's hard to believe that. But by the time I started paediatrics, and the other thing that happened is measles and whooping cough went through orphanages like bushfire. There were hundreds of poor kids, badly fed, and there was huge death rates. In Ballinasloe, that was standard practice. Lots and lots of babies died in orphanages. By the time I had started paediatrics in 1970, polio and diphtheria had been eliminated by vaccination. In my career, congenital rubella, tetanus, tuberculosis have all been eliminated. Measles and pertussis greatly reduced, and the impact of bacterial meningitis caused by Hib, pneumococcus, men B and C, and TB greatly lessened. We saw a lot of it. Rheumatic fever and scarlet fever have virtually disappeared. And happily, so have fever hospitals. It took a long time to close Cherry Orchard, far too long. For a couple of years in Templeton, I ran a so-called high-risk vaccination clinic for parents and doctors who had difficulty and children who were at risk, or so-called risk, of having a reaction. Several hundred children were vaccinated in the day ward over a few years. Nothing happened. No callbacks, no returns, no readmissions. And vaccination is safe. That was so thought to be a high-risk group. We closed the clinic. In my time, some of the best advances in paediatric care, clinical care, have included the input of clinical nurse specialists, play specialists, school teacher, and the emergence of multidisciplinary teams. Hospital decor, attitudes, facilities, parental accommodations have vastly improved, but are still not perfect. So much for a quick run through paediatrics. A few words before I finish in my current state, geriatrics. As a lot of pediatricians don't realize that, and I have this from Dermot Power, a geriatrician in the matter, husband of Nuala, that a major factor in longevity has been surviving childhood. Major factor, and still is. When I was appointed in 1978, the average life expectancy of a consultant after retirement was, any guesses? 2 years. Now it must be 30 years. Niall O'Donoghue in mid-90s, Seamus Dundon in mid-90s, and Barry O'Donnell still going strong. So there's been a very big change. I recently learned, and finally, in Japan, the population is living so long that more senior Pampers are now being sold there than baby Pampers. God forbid. Thank you.
So we're just going to keep talking for a few more minutes, and then we just want to have a discussion about anything we've raised, because we had a great time preparing for this. We've been off having coffee. We've talked about everything to do with paediatrics, past, present, and future. We sadly didn't go to the old St. Ultan's, to the hotel there, which would have been a much more appropriate place for a few drinks, but we will do that later again. So we're all kind of taking slightly different aspects, but I suppose I was just interested in, all of us, I think, are going past the future. So I can't really talk about it. I think I found this picture the other day, and I just thought it was so horrible and sad to see kids sitting in doorways in Dublin. And this kind of fits with, I put the proper reference to it from 1913 underneath it. And this would have been childhood poverty. And I think we all know that childhood poverty now and then is probably the biggest indicator of child health. And if we can remove childhood poverty, we can improve child health and have more people growing to healthy adulthood. And I think they had many conferences in 1915 and 16 because of childhood death. And again, then after the 1916, then they had the increase in syphilis. And I won't go into that. I have a very weird interest in syphilis, which I'm not going to go into now. But I think it's just to show the massive number of deaths at that time that we don't take. And I was just looking at this, say 1913, and it is hard to sometimes, because I'm not a proper historian, to look for these figures correctly. But if you think about, it's kind of roughly about 81 per 1,000 live births died. And there was also a huge mortality in the under 5-year-olds. But I was in the Foundling Hospital in London recently, and I think in the kind of 1750s, about 70, something unbelievable, like 75% of children in London died before their 5th birthday. There was a potential for that in London City. So we had improved, but look at us now, it's less than 3 per 1,000 live births. And that's not even the corrected perinatal mortality. And in Ireland, we still have a lot of our deaths are due to congenital abnormalities, which wouldn't happen in other countries. So I think our corrected is nearly 2 point something, if not less, which is really, really good internationally. So we have come a long way, but I suppose we're going to talk about, yes, how can we get further? Because just before I go to the next slide, I suppose the one thing that Denis mentioned, you know, the cutaneous measurement of all electrolytes, the use of immunotherapy instead of chemotherapy. You mentioned a few other things there. Every single one of those are things I qualified 25 years ago, and they were all things that 25 years ago we said are going to happen tomorrow, and they still haven't happened. And I am a little bit concerned that anything that's expensive, and this is what I'm getting onto now, might not happen for pediatrics in the near future unless we push. And I suppose today, gosh, it was very inspiring to see people really pushing for things because children, as you probably know, didn't have as many rights. And this really started a long, long time ago. But I suppose I always like to look at the rights of the child from Janusz Korczak, and I've definitely mispronouncing his name. And I'll talk about him in a second, but really the rights that he mentioned, and he's some beautiful books for pediatricians, and many of you probably know them, about how to look after children, how to love children, how to care for children, and they're very much about childhood autonomy from the Second World War. But I think a lot of this is, and this is coming to what we're seeing in our practice, is that children need to be informed of everything about their care, make decisions about what they're going to participate in, and so on. And I think that has always been part of pediatrics, maybe not as much adult medicine. And so Janusz Korczak was a famous pediatrician, and he had a children's radio, many of you might know this, he had a children's radio show that was very famous in Poland at the time. So he was extremely famous when the Second World War broke out. And he got lots of opportunities for amnesty during the Second World War, but he actually set up an orphanage in the Warsaw Ghetto. And he had a children's court for children. If they had a grudge against someone, they weren't allowed to fight it out. They had to present their case to a judge and have a full trial. And this is against adults as well. They had a complete right to autonomy, and he was trying to make children kind of persons of their own. And he also had children's newspapers and radio stations, not run by adults, but run by children. And I think this is something that has always been around, but I suppose he's written it very nicely, and it's easy to look at. And very tragically, this is kind of a recreation of him. He did go to Treblinka with all the children in his orphanage. Sorry, I think it's very sad. But the one thing about him is his life, his death is the thing that makes you read about him, but actually his life was amazing. And if you read anything about him and just look at some of his books, they're very inspiring about how we should talk to children. So this comes to inequality. And so even though things have improved and childhood poverty is better and things are much better for children today, and they do have more autonomy and parents have more autonomy, we still have a massive inequality. And this has been revised recently. So this came from the Royal College of Paediatrics and Child Health in the UK, and they were looking very much at research and have we got any academics in paediatrics and so on. And they are really losing their academics in pediatrics, and there's much less children's research and much less work on childhood research in general. And if you look at the bottom line, if you look at resources for children, the smallest children in the NICU, who might still be on 5 pressors, extremely unwell, the same number of medications as an adult, will not always get one-to-one nursing, and they use 100th of the resources are spent on them. And that is still, to this day, the same amount of money. So they're just getting a lot less than an adult. So an adult, according to the research, an adult who is terminally ill, who may be have had a long-term life-limiting illness will be considered to deserve more money than, say, a preterm baby who may live a full life and contribute to society, which is always the thing we think about. So I suppose this is a big worry. They recently updated this, and I think it's got worse, I'm afraid. So we do need to shout. And this is a slide just showing, if you look at the red, that's pediatric funding from the NIH in the States. And if you look at the blue, and this is old data, it's got worse again. In the States, that adult funding has gone shooting up. And this got revised a few years ago, and they found that it's still the same. So we probably do have a big fight in our hands to push for more resources for kids. And one of the things that's really helping us is the things that are happening anyway, is parents are participating and children in everything that we do. And I think that they pretty much, it's practically impossible now to get a research grant without having at least a group of parents on it, which is fantastic, because then you feel less coercive forcing them to be part of your research, because you all have to be together, and really making sure that we're aligning our research goals with parents. And I think you all know about the James Lind Alliance and how that incorporates parents in all our goals. And there's a few campaigns now saying that we should never have a medical meeting where we don't actually have parents on the podium, and that we should boycott meetings where parents aren't on the podium. And luckily, actually, I think all our meetings in paediatrics, many of them have parents on the podium. And so this is again to what Dennis said, and all I'm doing is the translational paradigm is only to say, yes, how come we're not using genomics all the time in pediatrics? In adult medicine, if you get a cancer diagnosis, your genomics are done, you see a cancer genomics specialist, this is all organized. This doesn't even happen in pediatric cancer. Why are all the diseases, we're still going back and doing randomized trials of different antibiotics? We're still not using immunotherapy, and there's not a lot of investment. Now, there is more money, as you know, through pharma, that they can't actually fund anything unless you use medicines for children and start to look at funding for children, but we're still a long way away. And things haven't gigantically changed in 25 years. So into the future, equality for children, and this on the side is what they're doing in adults. They're putting an organ on a chip, and they're trying drugs like you could have a lung on a chip. So it's the equivalent of actually, in a microscopic way, looking, instead of using animal models, you could look at a lung, look at drugs and how they work. We've never done that in pediatrics yet. Equality for children, access to healthcare. So they shouldn't have 100th of what an adult with the same amount of illness should have. And they should get access to disability care, which we know is very difficult for children. Resources equivalent to adults. Can we get some funding, please, for research? We should be really pushing medicines for children and insisting that that happens on a national level. And the most important is, of course, decreasing childhood poverty. But I think it's really helping that we have so much family-centred care and family involvement. And hopefully in the NICUs now in the future, we'll actually be having parents who are really able to deliver the healthcare for their children, which is the model in other countries. Thank you.
Good afternoon. I was already intimidated sitting up here with Eleanor and Dennis. I'll be honest, I was the only non-professor up at the table. And then I spent lunchtime looking around like a who's who of pediatrics. It was like a ticked box, all these famous names that I'd heard of before. So I'm delighted to be here today. And then I think Eleanor felt I got the easy one with the future, but I had no anecdotes about gorillas in PICU. I can't even wear a watch at work anymore, never mind admit gorillas to the intensive care unit. So I had to go with a slightly hypothetical version of the future. So what is that going to be? Well, my first thought in the future of medicine is I'm a bit of a nerd, and I immediately went to Star Trek. And I wondered when we were going to have that tricorder thing that they could have, which would be really helpful for the little infants who can't tell me why their tummy is sore. And then I discovered they've actually invented it. So someone in the States, a really, really, really rich person, has invented the tricorder that you can now scan an entire person, and it can listen to their breathing and their cough, and has something like a 95% accuracy for diagnosing bronchiolitis and pneumonia and things like that. So maybe next time when I'm on the past version of it, somebody will be talking about that as the present. Then they've also invented contact lenses that you can wear that will feed your glucose levels directly from your contact lenses into your insulin pump and automatically adjust your insulin pump. And then more apt to pediatrics, then they have invented this little thing, which if your child has swallowed a button battery, you can get them to swallow the tablet and it'll automatically go towards the button battery, open up and unfold it so that you don't have to have emergency ENT surgery in case it starts eroding your esophagus. All things that they're currently working on, fascinatingly, in the States. And then just a couple of other things which possibly might be a bit more apt to pediatrics. They've invented smartphone otoscopes, and recently I had a sore ear myself, and I could really have done with somebody holding it up to my ear because I could see myself, because my non-medical family couldn't tell me why my ear was sore. They've developed an app that can improve the lives of every neonatal SHO, where you can take a selfie and discover your bilirubin level. That would cut down on a lot of blood tests in the NICUs. And then in the Mayo Clinic in the States, they've started prescribing prescriptions of what they're terming digiceuticals. So as you're being discharged home, you're being prescribed certain apps to download onto your smartphone, which feed into either your Apple Watch or your fitness tracker, and it feeds back to your doctor in the Mayo Clinic, who can then keep track of your blood pressure and alert you if they're seeing a trend. And instead of calling you back in or perhaps missing something, they can contact you then and let you know that your blood pressure's gone up and it's tracking up, and they can change your medication. They've also got an app that you can use to retrain your brain to dampen down tinnitus, if anybody suffers from tinnitus. And then with the whole 3D printing thing, they're starting to just 3D print prosthesis, so they can measure your leg and get molds, and then they can just put it into a printer and 3D print out your new prosthesis, which will hopefully change that whole phenomenon in the future. And then from one of the things that I'm heavily involved in Crumlin is there are new methods of triaging all our GP referrals, which we spend a lot of time doing. But they've also developed a computer program that will now triage the letters and the complaints that the patients and GPs are writing in about. It taps into, again, your wearable devices and then decides whether you're routine, urgent, or soon, based on all those. So I could cut down a lot in my workload anyway. And then when I was doing this, I was contacted by the college and asked for a photograph, and I still don't know which one they've picked. So, but they asked for a photograph, and I said, no problem, I'll just pull up my phone and I'll get a photograph of myself. And actually, every single photograph of me is me and my children. And I have oh, there you go, thank you. I have absolutely no photographs on my phone of me on my own. Either my husband is in it or my children are in it. And really, that kind of jogged my memory that I really think this is the way we're going to have to go in the future. We all know that we've been patient-centric, but at the moment we have a bit of an issue recruiting nurses, we have an issue recruiting OTs, we have an issue recruiting consultants, we have 500 empty consultant posts in the country. And while, yes, I 100% agree that we have to be patient-centered, I think in the future, it's going to be even more important as well that we start thinking of our staff. We have particularly in paediatrics, we have a very heavily female-dominated trainees, but also we have a lot of young male trainees, and they don't want to work the 5 days a week. They don't want to work well into 8 or 9 o'clock in the evening, and they want to be able to go home to see their young families. And unless we start working with them to encourage that and to adopt nearly more of an NHS attitude where you get your job and you can go, okay, but it only works with me to work 75% of the time, and can you get somebody else to work 25% of the time? That's, I think, the only way we're going to get these people back from Australia and the UK, where they currently are, and we're losing all our talent to these countries that have adopted this more staff-centred modus operandi. And like in Australia, they hire extra staff because they know the nurses are going to go on maternity leave. They hire extra doctors because they know they're going to get sick or they're going to need to be post-call, and we're not doing that in Ireland at the moment because we can't hire enough doctors and nurses to do the things we need them to do. But maybe if we changed our kind of way of recruitment and working with our Minister for Health, we might be able to improve the staff-centred aspect of medicine. And my mother-in-law is a GP, and I told her I was doing this talk, and from behind the telly, I don't know why it's still behind the telly, she pulled out a thing from 1992. And it was a special version of the Irish Medical Times entirely on women in medicine. And I thought it was brilliant, and I took it home and I read it, and nothing has changed. Every article was about, we need flexible training. We need people to be able to work non-full-time. We need people to be able to, both men and women, to be able to go home and spend time with their families. And there wasn't a single article in it that actually really has improved dramatically, unfortunately. So it was a little bit depressing in the end. But it just goes to show that we still have a long way to go in working to get a healthcare service that really suits our staff so that we can bring all these brilliantly trained people home from abroad to work with our children. As the Ella Webb quote said, we know there's children out there who need help, and whatever the state of the country, we just have to work with them to get them better. And then just we had touched on things that had disappeared and differences between Prof Gill's career and mine. So I've never seen a case of epiglottitis. I have never seen a case of tetanus. I have never seen a case of diphtheria. I have seen one case of pneumococcal meningitis in my career, and I have seen 5 cases of meningococcal sepsis, whereas I think you were talking that sometimes you'd have 10 or 15 cases a night. I've never seen that. Up until I was a first-year SPR, I would have said I'd never seen a case of measles, and unfortunately that has skyrocketed since then, because we all know why. But I do wonder, with the advent of the varicella vaccine and the increasing uptake we're seeing, will I see the end of chickenpox by the time I'm on the other end of this table? Will measles have hopefully gone back down again? And you'd have to wonder, with all the huge research money that's been poured into adult medicine, will I have seen the end of HIV and hopefully the end of TB as well? Thanks.